the first presenter. A little over a year ago, I had the pleasure of meeting her as we worked together to produce our summer forum, the successful project delivery summits that we do each year. I was impressed by her passion and professionalism, so when we started discussing the need for a conference based on big data, I reached out to see if she'd be interested in participating. Not only did she want to be a part of the effort, but she felt her background and experience made her uniquely qualified to lead the effort, and now that I've worked with her for the last year, I couldn't agree more. Karen Johnson is the Chief Deputy Director for the California Department of Healthcare Services, and as so is part of an organization that has come to realize how critical big data is and is leading the way to implementing tools and processes to take advantage of its promise. Karen represents half of today's Keynote's presentation and will discuss the fiscal impact on her department's efforts to get their arms around this topic. When she's done, she'll introduce one of her partners in this effort so that you can also understand the impact on the residents of California. Please give a warm welcome to Karen Johnson.
Thank you. That was very good. I want to welcome everyone to today's conference. We hear the term big data almost daily. This term gets our attention in many ways. The infographic shown here highlights the overwhelming amount of data in our world today. This data represents both challenges and opportunities. Challenges come to us in the sheer volume of information, the unstructured nature of much of this data, the need for new ways to analyze and use the data, and the need to be respectful and protective of confidentiality of the data. Opportunities are highlighted in the way this data is being used to understand the spread of disease, such as the flu, and understand relationships and methods of communication. Understanding the best way to reach and communicate with the individuals that we serve to meet our mission. At DHCS, at the Department of Healthcare Services, we have highlighted this in our new strategic plan, which is focused on commitment to the public, to the people we serve, and to our employees. Data that is turned into information is fundamental to fulfilling our commitments, such as developing effective and efficient and sustainable healthcare delivery systems, holding ourselves accountable for performance, and being prudent, responsible fiscal stewards. Within government, we experience vast stores of data and data we are responsible that has multiplied in recent years. Yet, even in the context of the rich data world, we are challenged by the cost of data to get the systems out for analysis. This may include the cost of staff time, data programming, and data coding. Additionally, much of our data is still paper-based. This is hard for many to understand when data seems to be so readily available. Additionally, in healthcare, we work with very confidential data and take our duty to protect that data very seriously. Thus, managing expectations with respect to the availability of data is very important. While addressing these challenges, we're also focused on improving our communication based on the data that is available. We are committed to using data as we engage the public and our partners and impart our programs on the people we serve and the public. We believe the data and information can and should drive our decision making. I'm known to say, let the data drive the decisions. It also can be used to provide a basis for demonstrating outcomes and perhaps transform the way we approach our business. I want to share with you some analysis and use of advanced technology methods at the Department of Healthcare Services. Our budget is nearly $70 billion. I'm the executive that's responsible for program integrity over this program. We've identified through our medical payment error study that dollars are nearly $1 billion related to fraud, waste, and abuse. So in 2010, DHCS, Department of Healthcare Services, initiated the use of advanced technology methods and advanced analytics to improve payment accuracy and to help reduce the cost of physician services. We developed reports called individual provider claim analysis reports, or what I would say provider report cards, similar to like a PG&E statement that you could see. However, this is for physicians. And what we wanted to do is to take the providers to compare their practice patterns with those of their peers and allow higher cost providers to determine why their own costs are higher. What this did, as we tracked those groups of physicians over the next following 6 months, we saw a significant decline in expenditures by nearly 30%. I believe this effort served as a reminder to providers that we're carefully monitoring the services for which we pay. So today, during this conference, you will hear about many facets of big data and how it can apply within your organization. We encourage you to consider all aspects as you evaluate the impact on the data for which you are responsible for. So today, I would like to introduce our keynote speaker, Pamela Lane. I have worked with Pamela Lane for many years with the California Privacy Security Advisory Board meeting. She is our Deputy Secretary, Health Information Exchange for the California Health and Human Services Agency. She's responsible for the development of California's trust environment to enable electronic care data availability for Californians, whenever and wherever they need it. She was previously Vice President, Health Informatics for the California Hospital Association. She has over 2 decades of experience in health information management and hospital operations, leading system selection teams and redesigning workflow processes to optimize the best practice, experience, and revenue cycle in health information management. She's a veteran of U.S. Navy, having served as both a care provider and a commissioned line officer. She remains active in issues specific to veterans' health and military family support. So can I have a round of applause to welcome Pam Lane to the podium?
Thank you.
Thank you.
Good morning. So nice to see you all. I promise I'm not going to only speak about healthcare because I realize that not everyone here in the room lives and breathes that as so many of us here do. I understand that our attendance this morning is a wonderful mix of about 50% IT professionals and 50% program or business operations folks. And that is exactly what we need, in my opinion, to make big data work for all of us. For those of you who are not aware, this conference is being held simultaneously with another data conference here in the same building where we've been focused on open data. And Karen alluded to my background in the military, and I will tell you that I went from a patient care environment where I was dealing primarily with personally identified information into the intelligence field. Some folks think that naval intelligence is an oxymoron, and perhaps it is like large shrimp, but it was a great opportunity and a great way for me to learn about different ways of securing information and who truly has the need to know. And when it comes to big data and our applications of that, there is a great need to know. So for the IT folks in the room, you can probably tune me out here for a couple seconds. For those of us who are not IT professionals, though, I want to talk about how I respond when people say to me, how big is big data? My response generally, being the great techie that I am, I usually respond, it's really, really big. And it is really, really big. In fact, it's so big that we've had to create a new vocabulary to define storage space and amounts of data. And so I'm going to introduce you. I don't use PowerPoints. Some people hate that, some people love that, but I'll give you a chance, because I'm sure you're going to hang on almost every word I say. I'm going to give you a chance to pull out your pens and papers or your stylus and your iPad, because I'm going to give you some new vocabulary words that you may not have encountered before. So I remember the first time that I bought a personal computer a million years ago, and I was concerned about how many megabytes of storage that it had, and I couldn't even imagine what a megabyte was, but I knew it was really important and more was better. And then when I bought my first laptop, it was about gigabytes. And gigabytes, wow, those were bigger than megabytes. And I have since found out, as I've studied this more and become more of an IT knowledge-based person, that a gigabyte is 1,024 megabytes. And then the next step up is a terabyte. Kind of sounds like a dinosaur to me, but I think of things kind of out of the box. And so each of these steps is 1,024, is a factor of 1,024. So terabytes, wow, that must be a lot, because that's 1,024 gigabytes. But that's not where it stops. Petabyte is next, and then an exabyte, and you heard that on our Intel video, an exabyte, E-X-A-B-Y-T-E. And then the new word that I heard this morning that I had not heard before that was on that video was a zettabyte. So not to sound like a first grader, although sometimes that's what it takes to get our brains around this, big data is really, really big. And in 15 of the 17 business sectors in our country today, 15 of the 17 business sectors have as much information, big data, available to them as in the entire Library of Congress. That's each. So that's enough data to fill 15 libraries of Congress. Now, I don't know what the other two that are not in that group are, but I can tell you, I can assure you that healthcare is one of those 15 sectors. We have about 50 petabytes of healthcare information, and 90% of that has been created in the last 2 years. There's a reason for that, and we know in government that many times the answer to any question is follow the money. And the federal government has put a great deal of effort and money on the table for healthcare providers to electronically capture health information data. And so that volume, that wealth, that repository of health information data is growing in ways that we never thought before. 90% of the health information that's available today was not available 2 years ago. And it has been estimated that the amount of health data is going to double every 6 months from this point going forward. Now, those of you that aren't in healthcare, you're thinking, why do I care about that? Because everything you do and every decision you make, well, perhaps not every, but many, are made through the lens of your own personal health care. Everybody in this room, at some point in your life, has been a patient. And if I could have my most fond wish, it would be that you would never be a patient again, but that's probably not going to be the case. And when you are a patient again, I would love to be able to be the provider that has all of your historical relevant information in front of me so that I was not in the situation that I found myself in as a young Navy corpsman caring for Marines who were unconscious in front of me and I knew nothing about them. Fortunately, that I know of, I never cost anyone their life by not having their information, but I know how valuable it is to have the patient information in front of me. And so big data and health data is about you. I'm going to ask you to take off your government employee hat for just a moment and think about yourself as a taxpayer in California, and think about the efforts and the changes that we can make in your lives in California, the state of the state, if you will, of healthcare in California. And we have begun to use the information, the volumes of information that are available to try to change your health outcomes from this day and going forward. My colleague, Dr. Scott, reminded me yesterday that for the past 100 years in healthcare, we've focused on disease prevention and specifically infections, trying to control infectious outbreaks from a public health perspective. And that's true. And we still focus on flu prevalence in our community. We still are very concerned about infectious diseases and public health. But she reminded me, she's so brilliant, if you don't know her, you should. She reminded me that we'll be spending our dollars and our efforts and our attention in the next 100 years focused on chronic disease. Chronic disease prevention, because we know now from applying big data that many of the diseases that are chronic to those of us in this room and our families are preventable. So we'll be trying to prevent chronic disease, and we'll also be focusing on, unfortunately, the treatment of unprevented chronic disease. My generation was very lax about thinking about the future. We were going to live forever. I think every generation believes that way. We were kind of invincible, and I am reminded every morning from the aches and pains that what I believed when I was 20 is not true facing 60. And so there will be some chronic disease treatment, I'm sure, in my future. But what does that mean for California? What does that mean for you as a taxpayer, as a citizen, as a potential patient? Well, we've applied what we know in California about our citizens to a report that was not intended to be a shelf report. When I talk about a shelf report, you know, we create an awful lot of reports in government that just sit on the shelf. And I refer to those as shelf reports. This was not intended to be a shelf report. Some of you may be familiar with it. Some of you may not. I'm going to encourage you to look this up tonight. It's an easy read. It's called Let's Get Healthy California. And it is a 10-year plan for how to make California the healthiest state in the nation. Well, first of all, who's going to refute if we say we're the healthiest state anyway? Prove it. But it was this report and the work around this report were pretty phenomenal for government because it was created by executive order, and those who were working on this, including some of you in this room, had 6 months to prepare a report for the governor's signature that talked about how we would make California the healthiest nation in the country. Well, where do you start if you don't know where to start? You start with what you know. So this particular report started with, what do we know are the challenges in California? You can find this report on the chhs.ca.gov. In fact, it is such an important piece of work for us that we have a separate tab at the top, a number of videos, and this report looked at 6 priority areas in California. I'm going to share those with you in a moment. 30 priorities, and based on the findings of where we are today and where we want to be on data points. Data points that were already available, for the most part. Now, there are a few indicators for which patients will self-report, but for the most part, the data that we use to determine where we are today and determine where we want to be in 10 years, what will we consider to be success? Oh, and then let's also compare ourselves using those data points to the rest of the country. So if there's a national goal regarding childhood immunizations, Will that be the same as California's goal, or will we stretch a little bit further? So we focused on these 6 areas. The first 3 are health access across the lifespan. Healthy beginnings. We have the most indicators in our report, and what we're going to focus on in the next 10 years are in healthy beginnings, because that's where we begin to prevent chronic illness. Living well, which is hopefully that part of life where we all are, we're living pretty well. And then the end of life and end of life decision making. We know that those are 3 significant, very defined stages of life that we wanted to work on. We wanted to incorporate into all of these indicators health equity, eliminating the disparities in our communities. And the other 3 had to do with what we call pathways to health. Now, let me stop right there and say, put your work hat back on, because this is where your data and the health data that we have about our patients really can come into play. When we talk about creating healthy communities, and we talk about your community, are there safe places to walk? Are there sidewalks? Are there street lights? What are the public safety factors? What is the transportation? What is access to health care? Healthy communities. Oh, and let's not forget healthy food, access to healthy food, and all of the things that help make communities healthy. You have data about that. We know that those are impacts on our patients, on you as the patients in California. And so we factored in one of the 6 is creating healthy communities. The other 2 are redesigning the health system and lowering the cost of care. Obviously, our country's focused on lowering the cost of care. Karen talked about a 30% reduction in expenditures by just 1,000 of her 110,000 providers, I believe? Yeah, 110,000 providers in California. So if we could get that kind of reduction, lowering the cost of care, because people know we're looking at it, we're using big data to look at it, then we can impact our environment. So we created this plan. The 39 indicators, as I said, most of them are already publicly reported. Providers and hospitals are tasked with reporting over 1,100 quality indicators, nationally and at the state level. So we had a wealth of information already reported that we could pull from. And as I said, this is not a shelf report. It's not intended to sit on a shelf. We pulled it off the shelf within 6 weeks of when it was created, and have used it as a template for a state healthcare innovation plan that we will submit to the federal government by the end of March, that will make us eligible for a request to then submit further documentation and could bring $60 million into our state. But our plan has to have items in it that we can measure change in 3 years. Well, it's not easy to do anything in California in 3 years. And changing a culture from what it currently is and to a new place of wellness. So we picked very carefully from those 39 indicators in Let's Get Healthy California, the ones that we felt were the most readily applicable to a 3-year time frame. And we talk about things in our state innovation model like payment for palliative end-of-life care. Now, for those of you who don't know what I just said, because that sounded like a bunch of healthcare geeky talk, that means making sure that at the end of life, people have pain control. And most of us would really rather not be in a hospital at the end of our life. We'd really rather be someplace more comfortable where they don't wake us up in the middle of the night to ask us if we're sleeping okay. And but our payment system currently doesn't pay for hospice type care as frequently as the public would like. And so that also bleeds over a little bit, that was a gross healthcare analogy, wasn't it? Bleeds over, into the other area of payment reform. If we could keep people out of hospital beds at the end of the life and at home where they really want to be, and the payment system would support that, wouldn't that be a wonderful thing? So that's the kind of work that we're doing with the data points that we already have in healthcare. Now, all of us have heard those things like 10,000 steps a day for good care, 30 minutes 5 times a week for obesity prevention. And how do they know that? Because they're looking at big data across the board. They're looking at big data and they are figuring out where the opportunities are. So I want to talk just a second about what are the skills we need to manage big data. So whether you're IT or whether you're program and business operations, we have all this data, zettabytes. Wow, I can't even wrap my brain around that. How many zeros is that? Anyway, all that data, but how do we use it? So in 2008, a new term, not a new term, but a new application of an old term, came into play, and that's data scientist. Some of you may have a job classification of data scientist. Most of you don't. It is relatively new, and I wanted to spend a little bit of time thinking about what you need to know to be a data scientist. It may not be your job classification, but if you're looking at big data and you want to use that big data, you have to have a certain set of skills, a certain way of looking at it that's going to make you successful as a data scientist. And of course, the first thing I have to do is find my card. Oh, there we go. So remember when we were all in grade school and we had to learn the scientific method? I couldn't remember that to save my life. I had to go look it up on the internet last night. And so if we're data scientists, then it must mean we need to apply the scientific method to what we're trying to do. And the scientific method, for those of you like me who needed a brief primer on it, is number one, you ask a question. And I would change that in our world to what is it we want to change? That's the question. So we ask the question, do the background research, and in this case it may be what data is already out there that's available. Develop our hypothesis. So if we know what data is available, what data do we not have in the big data realm? Or what data do we believe might be out there that hasn't been captured in such a way as to apply to this particular question? And that's creating our hypothesis. Then we're going to test our hypothesis with the data that we've been able to add to this soup of data, if you will. Analyze that, look at what we've got, analyze it, and come up with a conclusion. And then, most importantly, what we sometimes most frequently forget to do, communicate our findings. There's an awful lot of information out there that's been pulled from big data, and people don't know that it's out there. I'm currently in the process of doing a data inventory of published reports from HHS. What do we already have as an agency that's out there available publicly? And that's not even including the work from my dear friends at OSHPD, whose mandate is to publicly report. Even without them in the mix, my agency has almost 400, actually 398 reports that are publicly published out there, and people don't know about many of them. So we need to communicate what's out there, and that gets me to the data scientist. So here's a definition I found of data scientist. My IT folks will take exception to the word hack, I'm sure. But here's the definition, and I loved it. And if we change hacking to coding, I think you'll agree. So a data scientist is where hacking skills, substantive expertise, and math and statistical knowledge intersect. That sweet spot where it all comes together is where the data scientist lives. So my challenge to you to be a data scientist is, do you have those 3 pieces in your portfolio? Do you have coding skills? Well, I must admit that's my weakness. I didn't come into this from the IT background. I sort of had to learn it after I got all the other skills. Substantive expertise, do you know your business? And the math and statistical knowledge for the intersection. So when I was doing the research, of course, where we all go to do the research, the great virtual library in the sky, I queried, what are the skills and traits of a data scientist? And it was interesting because the articles that came up were written by employment headhunters. And their articles had to do with questions that you ask in an interview to determine whether this is the data scientist that you want. And so here's what it came up with: curiosity. Curiosity was the first one. You have to be curious enough to want to solve the problem. Second was creativity. Not what we generally think about when we think about data. We don't generally want people to be creative with data. But focus, and I certainly understood that one, particularly as I was trying to learn in my early years some coding skills, and then of course the attention to detail. But here's the other things that I would ask if you have these in your portfolio for your world. Communicates effectively to business users. Are you, and then the reverse of that is, can you communicate clearly to your IT expertise? Because I have found that those two are the two sides of the same communication coin when we're talking about data. Frequently, our IT leaders and professionals don't necessarily speak the business speak, and I know that the business folks don't speak clearly enough to the IT folks. I actually met my husband 20 years ago on assignment in Panama, and his job, he was a coder, and I was the end user, and he would produce a product and hand it to me, and I would go, well, that's not exactly what I wanted. I'm surprised we still know each other 20 years later, because we went through that exercise over and over again. I was not communicating very clearly. He was over there. This is what he did. He made up his own swear words as he was trying to program what it was that his business user wanted. So communicating clearly, knowing the business. If we're talking about big data and we're going to pull from data silos that are not within our business realm. So if I'm talking to my peers at transportation and I'm trying to figure out, like in our model from Intel, I want to know when there's an accident that there's a real-time notice about where the closest facilities are to engage EMS immediately. Am I able to talk their language well enough to have that conversation? It sometimes requires a stretch. I know my business really well. I may not know yours so well, but I do know that the knowledge and the data that you have has an incredible impact on my world, and I need to be able to communicate that. Here's another one. Understand statistical phenomena. Statistics, I hated that class in grad school. But daggone it, I have to go back and use it an awful lot. I have to understand statistical phenomena. So maybe, like me, you need to brush up on your statistics a little bit when we talk about big data. Makes efficient predictions. Predictions. The predictions in this case have to be formed in the world of, have I incorporated all of the elements of data that might have an impact on the outcome of what I'm looking for? Can you predict what other data streams might be important to the work that you're doing? Can you provide production solutions? And can you work on a mass scale? For some of us, that's a huge stretch. I would be remiss if I were up here and had the opportunity and did not talk for just a moment about an area at HHS that I am responsible for. So I wear two hats. I'm the Deputy Secretary of Health Information, and I'm also the director of an office that many of you know of as Cal OHI. And in the early days, Cal-OHI, with one I, stood for the Office of HIPAA Implementation. That changed a couple years ago, and it is now the Office of Health Information Integrity. But I want to talk to you for just a moment. You can put either your patient hat back on or your government employee hat on, and let you know that HIPAA, I am here to dispel a rumor that HIPAA is about privacy. Because that is not what HIPAA is about. And unfortunately, we got hung up on the fact that it had privacy in it. What it has in it is the word accountability. So it actually stands for the Health Insurance Portability and Accountability Act. The P is not for privacy, it's for portability. It's for moving information. And HIPAA focuses on standards. I'm going to read this because I think that I'm going to read this right from the Federal Register. I think it's important that I get the words exactly as they were written. Standards and operating rules that facilitate the use of electronic transactions by creating greater uniformity in data exchange, reducing reliance on paper forms and manual processes to transmit data. Yes, there is a component of privacy, and yes, people did get all spun up and all excited about the fact that there were breach fines for the very first time, but HIPAA is about data availability. And so whenever you have a conversation with someone and they throw up HIPAA as the stop, the barrier, the obstacle, please let me know, because that's an opportunity for me to inform them that this is about portability. Yes, it was originally about health insurance portability, but it is now much broader than that. And as the federal government has pumped billions of dollars into the economy for electronic data availability, whether through formal health information exchange as a project, or whether it's about interoperability or standards, it is not about privacy. We have a huge change coming up this year in our standards in healthcare. We are moving from a structured data set to a completely different structured data set, and you'll need to watch for that. This is a very big year for healthcare, and I believe I'm about to get the hook over here from the edge of the stage. So let me challenge you to be data scientists, whether that is your job classification or whether it is not. Please be sure and let me know if I can help you in any way as you move through this world of big data. Healthcare has had structured data in some areas for a long time. We still have a lot of unstructured data as well, but as I read to you from the Federal Register, it is about the structure and the data sets to make the data available, and I am thrilled to be leading those efforts at agency as the Deputy Secretary for Health Information. Have a fabulous day. Go out there and put big data to work because it's really, really big.